Yeah, so the frontline treatment of Hodgkin lymphoma now, so not necessarily looking to the future, but now is a matter of hot debate. I mean, it has been for the last decade, really. And in the UK, our decision is: do we use ABVD or do we use escalated BCOP? Although we slightly modify it and use escalated BCOP DAC. Worldwide, BV plus AVD is also licensed and used in many territories. In Europe, it's only licensed for stage 4 disease, but it's stage 3 and 4 in the US. So really, we've got these three potential approaches. And the debate really is around balancing the efficacy with the toxicity. So I don't think anyone would deny that escalated BCOP-based approaches are the most efficacious. You're looking at 90% or more cure rates, even in stage 4 disease. So very effective treatment, but they are associated with increased short-term toxicity, such as febrile neutropenia, blood transfusion need, plus potential longer-term toxicity, reduced fertility certainly if you need 6 cycles, and a slight increase, but it is still there, a slight increased risk in second cancers, versus a BVD, where your cure rates in advanced stage disease are probably around 75, maybe at a push 80%, but very kind on fertility, very low rate of unplanned hospital admissions, almost no blood transfusion use, etc. And AVD brentuximab is probably somewhere in the middle. It's outpatient delivered. It certainly has less short-term toxicity than escalated BCOP, but it does cause peripheral neuropathy. And unless you use GCSF prophylaxis, which most people would use now, there is a higher rate of febrile neutropenia. But it is now showing not just a PFS advantage compared to ABVD, but also, crucially, a small but significant overall survival advantage. So this debate will continue. As I say, in England, we don't yet have access to BV-AVD. It's not reimbursed, although we're hoping it might be soon, but we'll see. So we'll be discussing very much the pros and cons of each of these three approaches, and we'll be using case studies, because ultimately it all comes down to the individual patient in front of you, what their priorities are, as well as what the outcome data from the trials would predict.